I am Dr. Abhijyoti Biswas, currently working as an assistant professor in the Department of Cardiology in UNMICRC Institute of Cardiology and Research Center. Today I am going to present my topic, Advanced Therapies in Management of Pulmonary Embolism. The term venous thromboembolism includes two entities, deep vein thrombosis and pulmonary embolism, amongst which 2/3 of the cases are of DVT and 1/3 of the cases have pulmonary embolism. The incidence increases with age and it is similar in men and women. Approximately half of the VTE occurs without any antecedent history of trauma, surgery, immobilization or cancer. Epidemiology. The global incidence of venous thromboembolism is 0.75 to 2.69 per thousand population. However, the Indian data states that the incidence is 15.9%, with about 80% of the cases having PE as the cause of mortality. The international registry ICOPER demonstrated that mortality rates of 58.3% and 15.1% respectively for massive and submassive pulmonary embolism. So, pulmonary embolism today represents the third leading cause of cardiovascular mortality, the first and second being myocardial infarction and stroke. However, compared to them, very little research has been focused on novel therapies aimed at reducing mortality and morbidity of the disease. So, there is a need for rapid promulgation of pulmonary embolism response teams concept and development of novel endovascular therapies to treat acute pulmonary embolism. Coming to the natural history, the data from the registry show that the 30-day all-cause mortality rates are between 9 to 11% and 3-month mortality between 8.6 to 17%, with pulseless electrical activity and multisystem organ failure caused by right heart dysfunction being the most common cause of death. So, an interesting fact is that following acute pulmonary embolism, it was found that resolution of pulmonary thrombi was mostly incomplete. In fact, lung perfusion scintigraphy showed about 35% perfusion abnormality in patients in a year. CTEPH rates were around 1.5%, with most cases appearing within 24 months of the index events. Coming to the recurrence rates, it was found that majority of the recurrence occurred during first 2 weeks, and the rates were around 2% at 2 weeks, 6.4% at 3 months and 8% at 6 months. Late recurrence rates were around 13% at 1 year, 23% 5 year and 30% at 10 years. So, coming to the classification of pulmonary embolism, now first is a massive embolism, or as per ESC criteria, it's high risk embolism. These are those patients who have hypotension, that is defined as a systolic blood pressure of less than 90 mm Hg, or a drop of more than 40 mm of Hg during the for at least 15 minutes. Also, these are those patients who need vasopressor support. They account for 5% of hospitalized patients, and the average mortality is around 30% within 1 month. Second is submassive or submassive PE as per AHA, or intermediate risk PE as per ESC. These are those patients who have right ventricular strain without hypotension. Now, these includes RV dysfunction, that is usually detected by CT-PA or echo, which shows RV to LV ratio of more than 0.9, or it may be because of RV injury, which is demarcated as an increase in the cardiac biomarkers such as troponins or BNP. Submassive PE accounts for around 35 to 55% of the hospitalized patients with PE. So, there is a difference in the AHA and the ESC definition, whereas AHA states that submassive PE is RV strain without hypotension. ESC criteria states all those cases of pulmonary embolism who do not have hypotension but have a simplified PACE score of more than 1. Following which, they further subdivide the intermediate risk into two subgroups, the intermediate risk high risk group and the intermediate low risk groups. The high risk group have both RV dysfunction and RV injury, whereas the intermediate low risk groups are the one who only have either of RV dysfunction or injury. So, the next is the low risk group. These are the patients who do not meet the criteria of submassive or high risk pulmonary embolism, and they account for 40 to 60% of all those patients of pulmonary embolism, and they have an average mortality of around 1% within 1 month. So, this is a tabular representation of the AHA and the ESC classification, and this is the PACE score, the original score and the simplified PACE score, which is used by the ESC for classifying pulmonary embolism. So, why is there a need to classify, to stratify this patient? This is because the treatment ultimately can be guided based on the severity of the condition. Like for high risk patients, anticoagulation is advised along with some advanced therapy. In intermediate risk group, anticoagulation is again the mainstay, but with advanced therapy may be needed in case of clinical deterioration. whereas in intermediate, low risk and low risk groups, anticoagulation may suffice as a therapy of pulmonary embolism. So once the patient comes to the emergency, we look for the blood pressure, we look for any any requirement of pressure, and if so, then the patient is classified as high risk group and the pulmonary embolism response team is called for. If no, then we look for all the biomarkers and RV strain. Again, if any of these are positive, and again we will stratify it as an intermediate risk PE. If none of the above, then it is a low risk PE. So along with this, the initial investigations, the labs, the echocardiography, ECG and venous Doppler, everything should be sent. An interesting point is if the probability of pulmonary embolism is not high, then D-dimer should be used for screening such patients, whereas if there is high clinical probability, then we should not wait for D-dimer, we should directly go for CT pulmonary angio. Amongst the factors which are used for stratifying the patient, we have already discussed about clinical evaluation, right ventricular size and function, and cardiac biomarkers, but the fourth one is the anatomical extent of the pulmonary embolism. Any saddle thrombus which is sitting in the main PA extending into the branch PAs is likely to result into hemodynamic compromise and should be treated as a high risk case. So the cornerstone of therapy of pulmonary embolism has been anticoagulation, but it has been found that even with anticoagulation, such high risk and intermediate risk patients have adverse outcome, and therefore there is a need for therapeutic escalation and need for some new advanced therapies. So what are the advanced therapies for pulmonary embolism? First is a full dose systemic thrombolysis, then half dose systemic thrombolysis, some catheter-based therapy with or without fibrinolysis, surgical embolectomy and IVC filter placement. Along with that, in patients who have hemodynamic compromise, they may need invasive hemodynamic support devices such as ECMO or any isolated percutaneous RV supports. So first, we'll discuss systemic fibrinolysis. It simply works by reversing the right heart failure by physical dissolution of the anatomically obstructing thrombus. The hallmark of successful therapy is reduction of right ventricular pressure overload. There are three dosing intensities that have been tried. One is the full dose systemic, which is the licensed. The other is half dose systemic, which is used off level, and third in order is low dose catheter directed therapy, which I will discuss later in my presentation. Now the FDA approved dose of thrombolysis is 100 mg, which is delivered through a peripheral vein over a duration of 2 hours, and the patients may be thrombolized even up to 14 days after onset of the symptoms. Intracranial hemorrhage is the most feared and severe complication. The results of thrombolysis in intermediate risk patient is 47% shows a reduction in all-cause mortality, 60% there is decrease in the recurrent PE. However, there is 2.7-fold increase in major bleeding and 4.6-fold increase in risk of ICH. Therefore, this needs for a modified protocol in the form of half-dose systemic fibrinolysis. However, half-dose systemic fibrinolysis with 50 mg altiplase showed increased requirement for treatment escalation later on, driven largely by rescue fibrinolysis or by catheter-directed therapy. At the same time, there were similar rates of hospital mortality, ICH, GI bleeds or anemia. So overall, there was not much benefit which could be obtained by half-dose systemic fibrinolysis, although it is used as in off-level in various high bleeding risk conditions. These are the thrombolytic regimens that are presently in practice, where we use altiplase, streptokinase and urokinase. One question which we often get is whether tenecteplase can be used or not. Well, the PLETHO trial shows some interesting result in this regard. It shows that thrombolysis decreased the frequency of all-cause mortality and hemodynamic collapse within 7 days of randomization. However, the majority of benefit was only obtained by a lower incidence of hemodynamic collapse, whereas the mortality, it did not show much benefit, not in the within 7 days or even after 3 years of the primary event. At the same time, there were increased risks of major bleeding and 2% risk of intracranial hemorrhage. Therefore, the results were not very much promising in the PLETHOS trial. There are a few additional benefits of systemic thrombolysis. One is prevention of recurrent pulmonary embolism by reducing the thrombus burden in the lower extremities via a systemic fibrinolytic effect. And this ultimately also improves chronic thromboembolic pulmonary hypertension or CTEPH. So why do we need catheter-based approaches? On one hand, we have the limitations of anticoagulation and systemic thrombolysis. On the other hand, the complexity and risk associated with open surgical embolectomy is pretty high in some patients. Therefore, we need some alternative to both these, and that is in the form of catheter-based therapies. The indication of catheter-based therapy as per 2019 ASC guideline, it can be used as an alternative to surgical embolectomy for patients in whom fibrinolysis has failed or is contraindicated. Also, it can be used as a systemic fibrinolysis in patients who have experienced hemodynamic deterioration despite anticoagulation. So, what are the benefits of interventional therapy for acute pulmonary embolism? One is it combines the local fibrinolysis with mechanical thrombus conditioning. So there is an increased efficacy of thrombus dissolution via high local fibrinolytic drug concentration, and there is a greater surface area of the thrombus that is exposed. Now at the same time, since the local drug concentration is high, the overall dose of the drug can be kept low. This results in decreased hemorrhagic complications. Also, it rapidly decreases the thrombus burden by pharmacomechanical means. Another interesting point is Steele phenomena, which is a limitation of peripherally infused systemic thrombolysis, in which the blood may actually be shunted towards the unobstructed pulmonary artery segments. Rather than causing thrombolysis, it may get shunted. So here we have a benefit with catheter-based therapies that it avoids Steele phenomena. So what are the goals of therapy? Now goals are different for acute high-risk patients and intermediate risk patient. For acute high-risk patient, it is a reduction of mortality, whereas for intermediate risk patient, it is to avoid a possible hemodynamic collapse and to expedite the symptom resolution. So complete thrombus removal is not the goal of percutaneous method. Instead, downstaging from a high risk to an intermediate or low risk PE is good enough. So what are the catheter-based advanced therapies? They're primarily grouped into catheter-directed thrombolysis, pharmacomechanical therapy, and catheter-based embolectomy. So what are the pre-procedural investigations? Primarily, patient may need a pre-procedural CT angiogram, and also we might need a pulmonary angiogram, particularly in cases where we need to be sure about the location of thrombus. We need to find the potential targets of therapy for identifying the thrombectomy device that should be ideal for the patient, and also to identify the best projections angiographically to optimize the catheter navigation. So first in order is catheter-directed thrombolysis. It refers to the administration of pharmacological thrombolysis via catheter-directed injection. The thrombolytic dose used is only 1/4 of that which is given systemically, that is around 20 to 24 mg altiplase. So this decreases the rate of major and any intracranial bleed. The two most commonly used catheters are Unifuse and McNamara. The operators typically use 4 to 5 French catheters, which are about 5 to 10 centimeter in length. So this is a videographic demonstration of the Unifuse catheter. Here we find this is on the left side is a Unifuse catheter, and the other one is the occluding ball wire which we will pass inside this catheter system. This ball wire is inserted, it provides the proper force for activation of the pressure response outlets. So wire is introduced to gain access, and the catheter is introduced over the wire. The catheter is directed to the material, to the thrombus inside the blood vessel, and we can see two radio-opaque markers which can be used to identify and for proper placement of the catheter across the thrombus. Once we have placed it, we remove the guide wire and we introduce the ball wire through the Unifuse catheter. Now we lock the occluding ball wire into place. So we see the ball wire is in position now, and then we will start infusing the thrombolytic inside the catheter. So what it does is the ball wire builds up the pressure inside the catheter, and once the lytic agent reaches the target pressure inside the catheter, the pressure response outlets will activate suddenly, and then the thrombolytic drug will be infused. So this produces a very uniform and even distribution of the lytic agent across the thrombus, thereby facilitating thrombus dissolution. So once the procedure is over, the catheter has been taken out. Risks and complications. Now, one of the major risk is ICH and non-ICH related major bleeding. Second is hemodynamic decompression, which may be triggered by rapid changes in RV afterload because of the passage of so many pulmonary wires and catheters. It can rarely cause hemodynamic decompression by cardiac perforation and resultant tamponade, or by ventricular arrhythmias triggered by the catheters which are placed across the RV. Third is acute respiratory collapse. It occurs because of distal embolization of the thrombi, resulting in sudden change in the ventilation perfusion ratio. Fourth is pulmonary hemorrhage. This can be because of perforation of small PAs, or because of some pulmonary infarction, or because of the use of the thrombolytic agent, which can cause increased bleeding tendencies. Next in order is pharmacomechanical therapy. Now, as the name suggests, here a drug is used, at the same time we use mechanical thrombus fragmentation, aspiration or maceration. This promotes thrombus disintegration by exposing a greater surface area of the thrombus. So first we will discuss ECOS, that is, it is an ultrasound facilitated catheter-directed thrombolysis, a specialized catheter which has two lumen. One lumen houses a filament with ultrasound transducers that produces high frequency low energy ultrasound, and the other allows local thrombolytic delivery through multiple ports along the length. So this is a low energy ultrasound which facilitates dissolution of the and dissociation of the fibrin strands, thus opening the thrombus ultrastructure. The theoretical advantage is more effective penetration, which can be achieved over a very shorter duration of time. So it mainly reduces the distal pulmonary occlusion, it increases pulmonary perfusion, and catheter may be placed in one or both pulmonary arteries, and the therapy is usually done over 12 hours, but it can be done, recent studies are showing that it can be done in as low as 2 to 4 hours. There are no completed randomized trials which compare the use of CDT and ultrasonography assisted thrombolysis. So this is the ECOS hardware system, which includes the ultrasonic core, an infusion catheter, thermal coupler and controller unit. This is an X-ray which shows the position of the ultrasonographic transducers in both the pulmonary arteries, and 12 mg of TPA was administered in each of the pulmonary arteries.
Advance the echosonic infusion catheter over the guide wire and across the treatment site. Note that radiopaque marker bands at each end enhance catheter visibility. Remove the guide wire and the infusion catheter is ready to receive the ultrasonic core. Gently insert the ultrasonic core within the treatment zone of the infusion catheter until the luer fittings can be locked. The echosonic endovascular system is optimized to deliver the drug only out of the side holes in the treatment zone, while saline coolant exits from the distal tip. Unlike other catheters, this system provides drug delivery lumen separate from the central lumen. Note that delivering the drug without the ultrasound may limit its dispersion, as the drug will follow the path of least resistance along the sides of non-ultrasound catheters. By contrast, activating the echosonic endovascular system generates a radial pressure in the treatment zone around the catheter. The pressure effectively drives the drug into the inner volume of the clot and immediately accelerates dispersion of the drug. At the same time, the acoustic energy conditions the clot by thinning the fibrin into individual strands. This increases the pore size of the fibrin mesh and allows for a more effective delivery of the drug deep inside the thrombus. As the drug moves farther into the fibrin mesh, it surrounds each fibrin strand and bonds with the newly exposed plasminogen activator receptor sites. The fibrin strands begin to dissolve, releasing red blood cells and other blood components trapped in the fibrin matrix. With the therapy complete, remove the ultrasonic core and place the guide wire back through the infusion catheter. Finally, remove the catheter, leaving the guide wire in place if necessary.
So there are a few trials confirming its use. The Seattle 2 trial, which was a safety and efficacy trial, and it was done in 150 patients with intermediate risk PE. The results show a mean RV to LV ratio decreased by 25%, the mean pulmonary artery systolic pressure decreased by 30%, mean modified Miller angiographic obstruction index decreased by 30%, and major bleeding occurred only in 10% of the patients with no intracranial hemorrhage. The other trial is Optimize PE, which tried several doses of alteplase, 8 mg over 2 hours, 8 mg over 4 hours, 12 mg 6 hours, and 24 mg over 6 hours. Interestingly, all 4 regimens improved the RV function comparable to 24 mg of alteplase. The Ultima trial used 20 mg of alteplase, which reduced the RV to LV ratio, but at 90 days the difference was no longer significant. Limitations of catheter-directed thrombolysis. The evidence supporting the effectiveness of catheter-directed thrombolysis is much less robust till date, and also it fails to reduce the thrombus burden in the lower extremities since it is acting only locally, and the risk of hemorrhagic complication is still present because we are still using a thrombolytic drug. So next in order is catheter-based embolectomy. It is used in patients who have complete contraindication to fibrinolytic therapy. It includes catheter-based thrombus maceration, rheolytic thrombectomy, and large and small bore embolectomy. The risks and complications. Thrombectomy devices carry a higher risk of intraprocedural complications than other procedures because the devices here are larger and they have a greater chance of dislodging the thrombi distally, thus worsening ventilation perfusion mismatch or precipitating acute RV failure. Also, the wires and catheters are much more stiffer and less forgiving and may result in inadvertent trauma to the pulmonary vasculatures. So first is catheter-based thrombus maceration. It may be performed with a modified pigtail catheter or by using peripheral balloons. It is helpful in hypertensive patient with totally occluded branch PAs. The maceration can establish some forward flow and decompress the RV. However, distal embolization may inadvertently result in patient deterioration. The evidence in favor is just limited to few case reports and series only. Next is rheolytic thrombectomy. The most commonly used catheter is angiojet catheter, which uses high-speed saline jet that travel backward from the tip of the catheter, creating a vacuum and the thrombus fragmentation effects. The catheter can also be used for intraprocedural pulse delivery of low-dose thrombolytic agents like alteplase 20 mg, retiplase 2.5 to 5 units, or tenecteplase 5 to 10 mg. However, it should not be used as the initial treatment in patients with acute PE because of safety concerns. So this is a videographic demonstration of the angiojet catheter. We can see that a stream of high flowing saline that jets backward, and this creates focused and directional thrombectomy for stronger forces. It is 8 French sheath compatible, and the length is 105 centimeters. So it is compatible with 035 wire. So it can be used in any vein that is more than 6 mm in diameter. We must keep that in mind. And we can see that it is a flexible hub. We can rotate and direct the thrombectomy catheter as per our requirement. So there are 2 radiopaque marker bands to help us identify and place the catheter across the thrombus. Once we are across the thrombus, we usually infuse with some thrombolytic pulse dose of thrombolytic agent, and we usually keep it for around a dwell time of 30 minutes. We give a dwell time of 30 minutes. Now, so after 30 minutes, we will, by which the thrombus will soften a little bit, we will start the process of rheolytic thrombolysis. As you can see that the thrombus is being macerated and sucked into the catheter. Simultaneous fragmentation is happening, and we can also change the direction of the ports. So the valve is so designed to improve the maneuverability and torqueability of the catheters. Coming to the complications, now this can cause profound bradyarrhythmia and hypertension, which can cause hemodynamic collapse and death. This mainly occurs because of the release of adenosine and bradykinin from the sheared platelets. Hemoptysis can occur, and it is actually an FDA black box warning for the use of angiojet. Other is major hemorrhage at access and non-access site, particularly hematuria is very common after the procedure. Next is large and small bore embolectomy. So this uses manual aspiration thrombectomy. There is actual extraction of the thrombus from the vasculature. However, this is quite challenging because the thrombi are frequently large and partially organized, making them very hard to aspirate. It is usually performed by large sheath or straight guide catheter advanced directly over the thrombus. However, specialized catheters like Pronto XL extraction catheter may also be used. The Aspirex catheter, it's an 11 French device that aspirates the thrombus. It has a high speed rotating coil which moves backward and creates a negative pressure for aspiration and serves to macerate the thrombus. There is limited data on its effectiveness and safety. So I'll go for videographic demonstration. So once the catheter reaches the thrombus, we can see that the coil has started moving, and this is creating advanced aspiration as well as a mechanical fragmentation of the thrombus. So there is continuous maceration that is going on by these coils, by these rotating coils. And as we can see, the clot is transported automatically. There is mechanical transportation of the clot which minimizes the chance of distal embolization. The next is the flow driver system. The flow driver system is a large bore device that mechanically engages the thrombus by 3 self-expanding nitinol discs which are used for aspiration of thrombus. So it causes 25% reduction in the CT measured RV to LV ratio, and there is 10% decrease in the modified Miller index. The device received FDA clearance for treatment in PE in 2018, and in current practice the device is often used only as a simple large bore suction catheter also without the use of nitinol discs. The FLAIR study was done which has shown there is a reduction of the RV to LV ratio by 0.39 from baseline within 48 hours after the procedure. So we'll go for demonstration. As we see, the catheter has been advanced into the pulmonary arteries. This is the Trevor 20 catheter, which is a large hole catheter, and this is the large bore syringe that is used for suction. Now these are the nitinol discs that come with the flow driver catheter. These are 3 nitinol mesh discs which are used to engage. They are available in different sizes as per the pulmonary anatomy which we determine angiographically. Now once a ultrasound guided access has been taken, we see that the catheter is advanced into the pulmonary artery. The guide wire is placed across the thrombus, and this is the Trevor 20 catheter which is placed just proximal to our thrombus. Now a negative suction has been created, and we open the check valve, and once the valve is opened, the clot is sucked into it. So initially we do an aspiration. If the thrombus is not completely cleared by aspiration, now we introduce the flow driver catheter as we take out the sheath, the the nitinol discs are deployed which engage the thrombus, and now the discs are pulled out to bring the thrombus into the catheter, and now the entire assembly is pulled out. So this is how the float driver system works. Next is indigo thrombectomy system, which is a small bore aspiration catheter. It does not require any fibrinolytic administration, and it works on the principle of continuous aspiration. It received FDA clearance in 2019. The extract pre-trial showed 27% reduction in the mean CT measures of RV to LV diameter ratio, and there were only 3 major adverse events during the trial. So once the catheter is placed in the pulmonary artery just proximal to the thrombus, now we have introduced the separator. This is a separator which works like a rota, and the other part of the two-way catheter is attached to the suction machine. So simultaneously we are using thrombus maceration and continuous aspiration to suck in the thrombus into our catheter. So once the thrombus has been aspirated, the flow can be established. This is a tabular representation of the several trials that I've already discussed. Next is Aspire-Max mechanical thrombectomy system. This aims to increase suction force to a 5 French or 6 French catheter via a uniquely designed handheld aspirator. So it has been approved by FDA for use in peripheral and coronary vasculature. However, it has not yet been tried on pulmonary embolism. So this is the handheld aspirator. As we can see, it has single hand actuation. It requires single hand actuation, and there is a one-way check valve to increase or decrease and maintain the force. And there is a high performance large lumen catheter which provides a closed system to reduce risk of exposure or any embolization. So the guide wire has been placed, and once we have to cross the lesion ideally with the catheter before starting aspiration. Now we pull back the catheter and we squeeze the handle simultaneously so as to for continuous aspiration. So we can give some touch up or spot aspiration by maneuvering the catheter accordingly, and it can be even used without the wire. Aspiration can be done with or without the wire. So next is angiovac cannula. This is a veno-venous bypass system. It is designed to remove intravascular material via aspiration. Here there is a bypass circuit is used, which has an inflow, that is the blood going from the patient to the extracorporeal pump, and an outflow, that is blood going from the pump back to the patient, and in between all the trapped material in thrombus is filtered out. An oxygenator can also be added to the circuit if needed. However, the data on the effectiveness is still limited, and it can cause major complications like hemodynamic collapse and RV free wall perforation. So this is the catheter system. This is the system, angiovac catheter system. So it is available in different sizes with different angulation. So this is an 85-degree catheter, and as is shown in this, as is explained in this video, so it is available in different sizes and with different angulation of the tip. So it's the large mouth allows for aspiration of the thrombus, and then subsequently through the inflow catheter it actually goes to the filter, of the bypass circuit, and all the thrombus is filtered out, and the filtered blood is again infused back through a separate vein. So now this is a tabular representation of all the different devices that have been tried and that are being tried for treatment of pulmonary embolism. Another option we have is surgical embolectomy. It is mostly used in conditions where clinical deterioration occurs despite anticoagulation, or in whom there is contraindication to thrombolysis, or as a rescue therapy in patients who are refractory to thrombolysis. It can also be used in patients who require some surgical therapy, like in the form of surgical excision of right atrial thrombus or closure of a PFO or excision of clot in transit. So the results are best when they are done before the onset of cardiogenic shock and multi-organ failure. And an important thing is to avoid blind instrumentation, because it can lead to major complications, and because the pulmonary arteries are particularly fragile structures. So extraction should be limited to directly visible clots. An important aspect is to reduce the morbidity and mortality in patients of pulmonary embolism is preventing the recurrence of pulmonary embolism. A meta-analysis shows that thrombolysis was associated with 60% reduction in recurrent PE compared with anticoagulation alone. However, for catheter-based approaches, there are till now no data available whether they are actually beneficial or whether they show any benefit in contrast to systemic thrombolysis in this regard. An interesting approach is the use of inferior vena cava filters. In acute VTE patients, it may be used in patients who have contraindication to anticoagulation or with recurrent pulmonary embolism despite anticoagulation. They appear to reduce the short-term risks, but they increase the long-term risk of DVT, and therefore they overall have no impact on the mortality. An important concern was that of those patients in whom there was a concern that subsequent PE would likely be fatal. Therefore, to confirm this, a pre-EPIC 2 trial was done, in which in high-risk patients IVC filter implantation was done along with anticoagulation and checked against anticoagulation alone. It failed to reduce the risk of symptomatic recurrent pulmonary embolism or mortality at 3 to 6 months. There are several complications associated with IVC filter. 50% remain permanently indwelling. Besides this, there are device-related complications like filter migration, strut fracture, strut embolization, device tilt, IVC penetration, perforation of surrounding structures, DVT, etc., etc. To avoid these complications, IVC filter should be retrieved as soon as no longer necessary. Take home message. So the risk stratification is a valuable aid to decision making, and it is the most important thing before we start managing any patient of pulmonary embolism. The first thing should be risk stratification. Subsequently, the treatment decisions should be based on patient's risk factors of bleeding, the extent and location of the thrombus, operators' expertise, and individual patient preferences. Till date, there is no data to support mortality benefit with any catheter-based approaches, and no prospective study has till now demonstrated a mortality benefit with the use of any interventional therapy in any population of patients with PE. However, we must keep in mind that these are novel therapies which need further larger studies to confirm their role in the modern-day management of pulmonary embolism. Thank you.